Okay, hello, everyone, and welcome. It's so good to be here again. If this is your first time with me on one of my webinars, I would invite you to go to queenquanta.com to learn more about me. But typically, I just jump right into the lecture series, and that's what I am going to do right now. Today, our Q4CD info session is about your breast health and the basics that everyone should know. At Q4CD, we believe in your empowerment through knowledge and advocacy. And so we're going to be adding to your knowledge base today, hoping you'll be able to advocate for yourself, a family, or a friend. So let's jump right into talking about your breast health and the basics that everyone should know. I am Dr. Williams, aka Queen, and again, you learn more about me at queenquanta.com. Today, this is what we will be going over. All of this good stuff. We may stop at the breast cancer treatment paradigm just for the sake of time. Cannot make this too long. We want this to be interesting for you. So let's just start off with some statistics here. So in the United States, the leading diagnosis for male and female, the top three are listed here. We will focus on the female side. You'll see that the leading diagnosis is breast cancer with over 200,000 new diagnoses each year. The breast cancer diagnosis is 1 in 8. So this is a pretty big number. Now, the actual number of what this case may be or the cases per year will differ depending on where you reside. But this information was taken from the American Cancer Society. So you may find further information there. So let's jump into talking about the basic in breast anatomy and breast cancer screening. It is important to get to know your breast. Doesn't matter how often you go in to see your primary care manager or how many times you're having your mammogram. You need to know your breast. So this is showing a side view cut through an anatomic representation or cartoon representation of a side view, sagittal view through you. The blue area here is actually your lung. In front of that are the ribs and then the muscle, showing that the breasts sit on top of the muscle. And this is called the pectoralis muscles. They're fatty component, lobules, and the milk production comes out of the nipple through the duct. And the thicker area around the nipple is called the areola or the nipple areola complex. But again, I've been asked, well, doc, I have small breast or I have an implant. Does that affect anything? Or my breast is too large, it's too much to cover. Does implant cause breast cancer? None of that does change what it is you're supposed to do. And there are no information or studies that I've known that show that implants causes breast cancer. However, it's important to know that when you have an implant in, that it may be behind the muscle here, or it may be in front of the muscle. Regardless of how small you think your breast may be or how large your breast may be, you need to get to know your breast by doing your breast exam. Having a breast implant does not preclude you or should not stop you from getting to know your breast or getting a mammogram. Another thing I'd like to point out is that when you're doing your breast exam, it's not only what's in front of you that's your breast. The breast tissue actually extend up to your axilla. Well, the axilla is also called your armpit. I know, right? Why do we come up with these words? Axilla, armpit, same thing. And in there, is where you also have lymph nodes. I do have another lecture where I talk about the lymphatic system. If you feel something abnormal under your armpit and it is not an ingrown hair, how you'll know if it's an ingrown hair, if it's very superficial, and within a week or so, it's gone. It's like a pimple. If it's a lymph node, it'll be deeper and mobile. However, this is not a decision you have to make on your own. You know your breast well enough or under your armpit well enough. If there are any changes, then you need to present and let your primary care know about that. They will be better able to tell you what is normal versus abnormal. So monthly breast exam does not replace getting your annual mammogram because there are things that the mammogram can see on the inside that you may not be able to feel. Conversely, Doing your annual mammogram does not preclude you from doing your monthly exam because there are 12 months that may pass and there are changes that can occur that you may be able to pick up sooner than an annual mammogram would. Now, in doing your breast self exam, you need to stand in front of the mirror, raise your arms, check under your armpit, and they have different ways of doing it, up and down or in circle. It can be done in the shower, in the bed. Be sure to squeeze your nipple. But the big thing is that you get to notice if there are any abnormality. Seeing these static pictures or cartoon depiction may be a little bit difficult. However, we do have free videos step by step on how to do your breast self exam. So I encourage you to set a time to do that, be it monthly, first of the month, middle of the month, etc., and to also get your annual mammogram done. Here's one of the questions I received from you. My mother had breast cancer. I'm 34. Should I get a mammogram or wait? Now, one of the most important things that I would need to answer this question, my dear, would be how old your mother was when she was diagnosed with breast cancer. Nevertheless, if you're on, here is what needs to be done, right? So let me take a step back and address everyone. So a mammogram or screening mammogram is typically done for women who have average risk. You are average risk if you have no personal history of breast cancer, no family history, no known genetic mutation, never had radiation therapy to the chest wall for another type of cancer when you were younger, then you'll be considered an average risk person. If you have any of these, then you go into the high risk. So this person here who has a mother who had breast cancer, she would be considered high risk, and a mammogram recommendations may be a little bit different. For average risk, screening mammogram is recommended at the age of 40. Now, I know there were some guidelines that saying 45 or 50, but here I think the acceptable baseline mammogram is set for age 40. If you are considered to be in the high risk for all the reasons mentioned previously, then you should have a mammogram 10 years earlier. So in the example, the young lady sent me the question saying that her mom had the breast cancer. Let's say her mom had breast cancer at age 44. Then she should be getting her screening at age 34, 10 years earlier. Now, it's important to know that, the youngest person I've treated was 27. So that child, therefore, would we do a mammogram screening at 17? No, but they can at least do an ultrasound or do more self-exam, etc. But the fact that the person is in a higher risk group, then they would discuss what's the appropriate screening that's needed. The first step, though, is knowing your family history, and then your primary care manager can guide you in the appropriate direction. And it's also good for you to know, just in case you're with a group or, going to a new person and they're not aware of what the screening is, you can say, hey, this is what I've heard or watched on this webinar. So that's always good to know. Now, one of the other questions I always have is about learning about the breast density. Whenever someone has a mammogram, the question always comes up, doc, I've been told my breast is dense. What does that truly mean? Or intermediate or a fatty breast, nothing to be offended about. It's just what they're seeing in the mammogram. As an example, what you're seeing here in front of you are examples of different density of the breast. So this breast right here they're very dense looking at this, right? Compared to this breast here that's intermediate. And this breast here is actually quite a fatty breast. Now, these are just different angle at which they are looking at the breast. Why, when you have the mammogram, they'll squeeze your breast in different direction so that they can see the muscle area as well as all the breast in front of you. So not having a lot of breast tissue or having too much breast tissue is not an issue. Your mammographers are expert in being able to get your entire breast in there, and they know exactly what to do. So not to worry, allow them to do their job in servicing you. Now, there will be some abnormalities seen sometimes, and you may hear about calcifications that are seen. So the coarse calcification may be related to milk ducts that have calcified over the years, or it may be a tight cluster of new calcification seen. Now, you won't know that, but if you're having your mammograms regularly, then your radiologist will be able to see anything that's new cluster of microcalcification there, and they would therefore recommend further evaluation. So now the questions, like, Doc, how do I know I have breast cancer? What should I look for? Oftentimes, over 50% of the time, there are usually no symptoms. It's just an abnormality on the mammogram that was found. If you or a significant other found something in your breast, it may be painless, a firm mass, it may be a persistent change to the breast, thickening, swelling, dimpling. There may be changes to the nipple, such as an ulceration, which is like a sore that develop. You may have nipple retraction, inversion, or you may have discharge that may be bloody or yellowish. So any kind of changes, that is why these exams, self-breast exams, are so important. I have known patients who have had their mammogram was normal. 6, 7 months later, something was felt within the breast. So within that short time, something could have grown, something could have changed. Not to say that will happen to you, but it's all about just knowing your breast and knowing what is normal or abnormal for you. Then, I have no cancer in my family, doctor. I only have diabetes and heart disease. Am I still at risk for breast cancer? Yes, yes, and yes, because your risk is not only based on your family history, but on your biological sex, being a female gender, the age of your first birth, and then nulliparity, meaning you had no children, so you had a longer time of exposure to estrogen. Then along that line of estrogen exposure, when did you have your first menstrual cycle? Was it younger than 12, older than 12? And then when did you have your menopause? Before 50, after 55? And then you can look at the year spans between those to see how long you have been exposed to estrogen. And did you use estrogen postmenopausally for hot flashes or anything like that? One of the leading risk for breast cancer, however, is age. So age over 50, prior breast biopsy, or history of cancer when you were younger, treated with radiation, puts you at an increased risk for breast cancer. My grandmother had breast cancer. Will I have breast cancer too? Well, your risk will be increased. However, let's look at what will increase your risk here when it comes to family, right? So if there's a first degree relative, a mother, sister, daughter, then if there's only one person, your risk is increased 2 times. If you have, for example, a mother and a sister who have breast cancer, then you have 5 times the risk of getting breast cancer. Second degree relatives, such as your lovely grandma here, will increase your risk by 1.5%, 1.5 times, excuse me. If you are of Ashkenazi Jewish descent, you're at increased risk as well. Familial breast cancer, meaning genetic mutation, only family genetic mutation, only account for about 10% of patients diagnosed with breast cancer. So P53, BRCA1, BRCA2, which we refer to as BRCA1 and BRCA2, those are only involved in 10% or less of patients diagnosed with cancer. So you don't even have to have someone in your family line that has cancer to be at risk. So if you're adopted and you don't know your family history, that's okay. That get on the normal screening pattern that we have discussed previously. I'm 38 and I felt a lump in my breast. Is it cancer? Well, if you've been doing your regular monthly exam, is this lump new? Is it during your menstrual cycle? Have you been told you have fibrocystic or lumpy breasts and you're between the age of 20 to 40? What other changes are there? Remember, we discussed the changes earlier, any skin changes, nipple discharge, etc. Any changes that you have noticed, you can keep track of that. And I said, it's reasonable to see, if it's still there for 2 weeks. If it is, then you should speak with your primary care. The first time you notice it, it's new, you're concerned, the very first time you should try to get out an appointment. Typically, it takes about a week or two to get into an appointment so that by the time you get there, if it's still there, then you have to have a discussion. If it's not still there, then you can talk about what it could have possibly been and what you need to do in regards to being aware of these things. What can I do to prevent breast cancer? Well, first, before we get into that, we have to understand the difference between cancer prevention versus cancer risk reduction. So I will take this time to make a plug for two common cancer that we can actually prevent. And the first is cervical cancer. When you have your regular exam and when you go in for your pap smear in the years, that's been changing. That's a changing thing. So talk to your primary care. I think if you have a few that are negative after a couple of years, then you don't need to go back beyond the scope of this. However, when you go for your exam and they do a speculum exam, this here is a vagina that leads up into the womb. Between the vagina and the uterus, also called the womb, is where the cervix lie. So if there's any abnormality seen along this area, they can actually treat this locally and prevent it from becoming cancer. Now, there are some debates out there regarding HPV and should you get the HPV vaccine. Again, that's beyond the scope of this simple presentation. You really need to have a conversation with your PCM. Another thing that we will discuss that you can prevent over 90% of the time, I say 80 to 90% of the time, always leave that caveat window, right? There may be 10, 20% chance that this doesn't cover it. So don't say, doc, you said that if I did it would prevent it. In 80% of times or so, and this for colon cancer, they would do a colonoscopy, which still remains the gold standard, and they'll advance a scope. You will be in twilight or asleep for this, by the way, so you won't feel it or be aware. But they advance the scope up through the anus, through the rectum, and into the colon, the large colon, looking for any abnormality. This here shows a magnification of this area, and a polyp was seen here. Now, this polyp can be removed, and bam, just like that, you've prevented that from becoming a cancer. Now, there are other things we are so much trying to get the population to have colon cancer screening that we will even just do a stool sample just to make sure there's no blood. Now, this is very small, so it may or may not bleed. So you may miss this with just a stool sample. I say just grit down and say, okay, I'm going to do this. If you're 45-year-old African American, go ahead and schedule your colonoscopy. If you're 50, go ahead and schedule your colonoscopy. You need to find out from your PCM if you're average risk or high risk. Go ahead and schedule. Now, the risk is that if this is not removed during a colonoscopy, then it can grow and become cancer and spread. So let's try to prevent that. Now, these two cancers I discussed can be prevented over 90% of the time, 80 to 90% of the time, if these screenings are done. For breast cancer, we don't have a way to prevent it, but we can reduce the risk of it recurring. What can you do? Your health. Exercise on a regular basis. And we're not talking about hitting the gym and lifting weights. No, something simple as yoga. Well, I take that back. Yoga is not simple, or Tai Chi. Trying to maintain these posture actually takes quite a bit of energy. It takes a lot. So if you're doing something like that, or even riding the bicycle or going for walks 3 to 4 times per week, you are doing fantastic. Also, again, remember, if you're postmenopausal and you're taking postmenopausal estrogen for hot flashes or vaginal dryness, just be sure you have a balanced conversation with your PCM about the risk of increasing your risk of breast cancer. Now, smoking is just bad. Cigarette has so much poison in it. It's responsible for all sorts of cancer. Breast cancer is one of it. I know, being prior military, that sometimes this is what we used to do, right? That you get your cigarette breaks, or back in the Vietnam days, you used to have cigarettes in your canteen things. And, No, not putting blame here, but if you have this habit, try to work on smoking cessation because you'll be preventing a lot of different types of cancers, head and neck cancers, lung cancers, all sorts of different cancers. So it's just something that's not good for your health. So start working now at reducing the number of cigarettes that you are using. Alcohol intake also can contribute to increasing your risk of breast cancer. I know you said that you probably heard, hey, I thought a glass of wine or two is okay. Cannot have that debate right here today, but having a glass or two of wine versus a whole bottle of rum or whiskey, it really just depends, right? It's a balancing act. I always say everything in moderation, even moderation. So while I do not encourage you drink a whole bottle of your choice of beverage here, alcoholic beverage, having a glass or so of wine is usually okay, but always introduce my caveat. Talk to your primary care because you may have something wrong, your liver or something that I'm not aware of. So you always talk to your primary care about these things. Breastfeeding may also contribute to lowering your risk. Now, at the age at which you stop breastfeeding, beyond the scope of this, I've seen folks going to the age of 5 and 7. To each his own. But again, you could decide whether or not, what age you want to stop doing breastfeeding, right? So be physically active, maintain your weight, limit your alcohol intake, stop smoking. Breastfeeding may play a role, and think about your postmenopausal, post-estrogen use. How is breast cancer diagnosed? So let's take a look into that. So I need a biopsy. What's next? I have a very small video as well that talk about what happens with a biopsy and what to expect and what to do. When you have a breast biopsy, a radiologist or a surgeon will do that. They'll numb the area locally and then they'll send a sample to the pathology for review. He or she will take their time to review that, and during that time, it may cause a lot of apprehension, and the apprehension is real. Know, however, that the pathologist is making sure that they're making the right diagnosis, right? So it may take a little bit of time to get all the right information that's needed, typically about a week or so. But the apprehension is real. And now is the time. It should always be the time to have prayer and relationship with Christ, right? But regardless of what your faith may be, now is the time to try and center yourself. Think about what the results will mean to you, etc. But I want to acknowledge that there is a lot of anxiety and fear associated with the weight. Know that your team is aware of that and they're doing their best to get the correct information to you as soon as they feasibly can. So the next thing, therefore, will be talking about the breast cancer paradigm. We are called Question for Cancer Doctors because we understand that there will be at least 4 doctors in your treatment process paradigm that you will meet. The radiologist will always be a part because they're the one who do the imaging. Then you have the breast surgeon, plus or minus a plastic surgeon, medical oncologist, radiation oncologist, and usually the gatekeeper is the PCM. Whoever else is on your cancer care team will depend greatly on your location, whether you're in a clinic or a hospital, etc., as to who will be a part of your team. However, just as how we ladies do not purchase the first pair of shoe that we see, and if you're like me, I see something cute and I order it, and then it came out. I was like, that's not what I asked you to bring. That looks like a boat. That doesn't look anything like that small, cute shoe at all. Right. So we try different things out. When you went to purchase a car, you didn't take the first one. You want to go for a test drive. So that being said, I want to empower you to be a part of your treatment decision. Join up with them. The best way to be a part of your treatment decision really is to understand what all of these medical jargon means. And Q4CD has established some courses to help you understand that. That's why we are a nonprofit program of Quanta Q to help get this information out at the simplest format. Regardless of what the cost may be for some of the videos that are done, we want you to understand so that you can engage your team. Now, just as how you don't purchase the first thing that comes along, it is also okay to get a second opinion. Trust me, your radiation oncologist, medical oncologist, or surgeon won't be offended, not the least. But we will say that if you do go and get a second opinion, make sure it's an opinion regarding the treatment recommendation. It's your job, sort of, to understand what the breast cancer basics are. What does it mean? What's ER receptor, PR receptor, so that you can truly get to the core of the treatment options available and the recommendations. Now, third and fourth opinion, that will go forever. You don't have that much time to waste. You cannot wait for 6 months after a breast cancer diagnosis to try and do something if you're told you have a certain stage, etc. But it's reasonable once you have a diagnosis to try to say, okay, maybe I should have at least one other opinion, a second opinion regarding this, that, or the treatment. Here at Q4CD, however, we're helping you to understand the basics that you need to know. Therefore, you can talk about the treatment recommendation and be a part of the decision-making process. Before treatment recommendations can be made, do not waste your time to get a second opinion if they don't have the pathology report available or the staging is not done. So this is the core of what makes up any treatment recommendation. So in addition to knowing the receptor status, which I have another presentation talking about triple negative breast cancer and what it means with this receptor status, and also another presentation regarding grade versus stage, that they are not the same. So there's certain information that you need to have about the cancer staging before any treatment recommendations will be made. While you're waiting on these, this can also be an anxiety producing time because you are waiting again yet for more information. So be prayerful in everything that you do, learn about the basics that you need to know, and then march forward appropriately. So we've covered a lot in this short time, and this really is just to give you an overview of breast health and the breast cancer, right? So we went through statistics, anatomy, screening, risk factors, and how breast cancer is diagnosed. And I tried to answer some of the more common questions along the way. There will be webinars that will be available on q4cd.com. You can join up for those, and hopefully I'll be able to answer your questions during those as well. As for the breast cancer treatment paradigm, you'll have to go to the breast cancer course to learn more about your surgical options, what chemotherapy is and endocrine therapy, and to learn more about radiation therapy as well. So I want to thank you so very much for joining me for this info session. I hope this was simple for you and that you have added to your base knowledge, and this will help you to be a better advocate for yourself, a family member, or friend. Again, my name is Dr. Williams, aka Queen, your family-friendly cancer doctor. I hope you can join me for more sessions like this in the future. You may learn more about me at queenquanta.com. Until next time, I want to wish you peace in your journey. Bye now.